Good morning, everyone. Thank you to Pheochromocytoma Alliance for organizing this wonderful event, and I thank the organizers for having me here. I had the opportunity to speak at this conference 4 years ago, and I think this is a great venue for patients and physicians to interact in this field. And at Upstate, we're really fortunate to have our dynamic urology department under the leadership of Dr. Brzozowski, where we are able to keep up with the advances in the field. So I'm really delighted to be here today to speak to you about this on this topic. So the topic today is what every endocrinologist and physician needs to know about pheochromocytoma and paraganglioma. And my disclosures are none. We are going to discuss a little bit about epidemiology of pheochromocytomas and paragangliomas, and then we will discuss a clinical presentation of these tumors, and then understand which are our patients who are at high risk for these tumors. So a little bit of a historical perspective here. It was in 1855 when Dr. Addison first described the importance of adrenal glands. And over time, it was only in 1886 when first chromaffin reaction was described. And in 1912, it was Dr. Pick who coined the term pheochromocytoma for the first time. Leading on further advances, it was in 1926 and then in 1927 when the first surgical removal of adrenals took place in Europe and United States, respectively. And we all are somewhat familiar with the definition of pheochromocytoma by this time. Pheochromocytomas are rare neuroendocrine tumors that arise from chromaffin cells of the adrenal medulla. So these are adrenal tumors that produce excessive catecholamines, and they can be explosive in terms of symptomatology because these are highly vascular tumors. And when in 1912, Dr. Pick coined the term pheochromocytoma, he literally called them dusky tumors. That's because on staining with chromium salts, the tumor turned into a dusky color. What about paragangliomas? So paragangliomas and pheochromocytomas, these are terms which we use interchangeably in clinical practice. While the pathology is the same, there are certainly some distinct differences or features that distinguish these tumors. Paragangliomas are extra-adrenal tumors. The sympathetic nervous system is also composed of chromaffin cells, and whenever there is a tumor arising from the sympathetic ganglia, that is what is termed as paraganglioma. Paragangliomas are primarily located in abdomen and mediastinum, unlike pheochromocytomas, which are adrenal gland tumors. But we also know of paragangliomas that arise in the head and neck. And what's the distinguishing feature here is paragangliomas of the head and neck arise from the parasympathetic ganglia. So these are oftentimes non-functioning tumors. About the epidemiology here, it is a rare tumor. So overall prevalence of pheochromocytoma or paraganglioma is 0.1%, meaning of all the hypertensive individuals, it's only 0.1% of those hypertensive individuals have pheochromocytomas or paragangliomas. The annual incidence is reported to be about 500 to 1,600 cases per year. These are tumors which are often mentioned as frequently sought and rarely found. And the reason for this is with the advancement in technology and imaging, which we do for multiple other reasons in patients, we often run into lesions that are so-called incidentalomas. And for patients here, incidentalomas are purely incidental findings on imaging when a patient is undergoing CAT scan or any sort of imaging for other reasons. And here you have a small lesion sitting in the adrenal gland. And that's what it's called, an incidentaloma. It is important to know this because some of those incidentalomas may be functional, while majority of those incidentalomas are non-functional. So in the pheochromocytoma world, 25% of all pheochromocytomas are incidentalomas. Conversely, about 5% of all incidentalomas are pheochromocytomas. So from a clinician's perspective, from an endocrinologist or primary care perspective, it is important that these incidentalomas are evaluated for their functioning status. In terms of some facts around pheochromocytoma and paragangliomas, they occur in persons of all age, although the peak incidence in adults is between the 3rd and 5th decade of life. It occurs both in females as well as males. It is seen in all races, although there is some literature supporting that they are diagnosed less frequently in blacks. In over 50% of tumors, genetic defect is known, and 40% or so are germline mutations, and about 25% harbor somatic mutations. And we're going to learn more about genetics later this morning in another talk. But up until now, 19 genes were known, and in the last year, 3 more are known, so altogether 22 by now. This is important because there are certain familial syndromes that are associated with pheochromocytomas. Classically, we knew of VHL, MEN2, and neurofibromatosis. These are the syndromes that are associated with pheochromocytomas. Out of these 3, MEN2 is the syndrome which has the highest risk of pheochromocytoma, so more than 50%. It is important to know the genetic mutation because genetic mutation often defines the location of the tumor, it will define the secretory profile, and it will define the risk of malignancy of these tumors down the road. And then for paragangliomas, we have familial paraganglioma where the risk of tumor is about 20%. So I'm not going to go into much detail about these tumors because we're going to learn about this in another talk later on. But we know about von Hippel-Lindau disease. This, from an epidemiological perspective, there are about 20% of these patients who will develop pheochromocytoma. And out of those, about 50% or so will have bilateral pheochromocytomas. These are primarily norepinephrine-producing tumors. And then there are certain other features that give away the diagnostic criteria here for the von Hippel-Lindau disease. Coming on to MEN2, this is the familial syndrome, which is related to the highest risk of pheochromocytoma out of all familial syndromes, so 50 to 75%, out of which 50% of patients will have bilateral pheochromocytomas. These are epinephrine or norepinephrine-producing tumors. In neurofibromatosis, these are epinephrine or norepinephrine-producing tumors, but out of the 3 familial syndromes that we discussed, this is the tumor that has the lowest risk of pheochromocytoma, so about 1%. And then there are other features that together make the diagnosis of neurofibromatosis. Now, there's a distinction between pediatric population. I'm an adult endocrinologist myself, so I don't see peds population, but there are clearly distinct features between pediatric and adult population. In pediatric population, we see sustained hypertension, whereas in adult population, we see paroxysmal or episodic hypertension. But there's also a difference from an epidemiological perspective. It's only about 0.1% of hypertensive individuals who are adults that we see pheochromocytomas in. But in pediatric population, it's about up to 1% of pediatric population that with hypertension can have pheochromocytomas. There's also a difference in location. So in pediatric population, about 25% of patients will have bilateral occurrence of pheochromocytomas. In adults, it's about 10%. There's also a difference in terms of genetic composition of these tumors. In pediatric population, more than 50% of these tumors will have germline mutations. And in adults, about 30% have familial pheochromocytomas. There's also, in terms of extra-adrenal occurrence of these tumors, how many of those tumors will turn out to be malignant down the road. In pediatric population, up to 40% of extra-adrenal tumors are going to be malignant, whereas in adults, a little bit less, so 25% of extra-adrenal tumors are going to be malignant. Peak ages, of course, pediatric population is 10 to 13 years, and we talked about in adults, it's primarily the peak ages between 3rd and 5th decade of life. There is also a male predominance in the pediatric population, whereas when it comes to adults, we see this tumor arising both in men and females. equally. So coming on to the clinical presentation, we know about the 5 Ps in this, from this tumor: pressure, which is primarily related to hypertension, pain, perspiration, palpitation, and pallor. Whatever we know as classic triad for pheochromocytomas, the episodic headache, the sweating, and the tachycardia, the truth is that in majority of the patients, we don't see that classic triad. What is very pertinent in this patient population with pheochromocytomas or paragangliomas, it is paroxysms. These paroxysms is what actually gives away the diagnosis, and oftentimes these paroxysms are of time frame less than 30 minutes. They can be up to 60 minutes, but they're typically less than 30 minutes. These paroxysms are either spontaneous or they can be elicited. They can be elicited due to various factors. Some of these are medications which are dopamine receptor antagonists, corticosteroids. Something as simple as histamine can precipitate these paroxysms. Anesthesia, the procedure itself can elicit a paroxysmal response in a patient with pheochromocytoma, but on the other hand, it's also the medications that are used during the anesthesia procedure that can precipitate a paroxysm. Micturition, this is primarily pertaining to bladder paragangliomas. Then there are mechanical factors, something as simple as a strenuous exercise or activities that may increase abdominal strain. It may be lifting or straining. They will increase abdominal pressure and may end up precipitating a paroxysm. Then there are some foods that can precipitate paroxysm in these patients. The wide variety of these paroxysms is very variable across the patient population. It can be something as occurring every day versus a patient may just come to you and say, I've only happening this once a month or once every few months. So it's very variable across the board. The 2 reasons why these symptoms are happening in these patients is primarily one being catecholamine excess, and the second is mass effect. The catecholamine excess is which is primarily giving the predominant cardiovascular symptoms that we see in these patients. So chest pain, angina, this is happening because of the coronary vasospasm or because of the increased consumption of oxygen at the level of the heart. Long-standing hypertension can itself also induce diastolic dysfunction, and over time, systolic dysfunction can follow. Patients can also get cardiovascular conduction defects, irregular heartbeat, things. These are going to be very commonly also noticeable over time if the condition remains untreated. And then there's other non-specific symptoms which are also related to catecholamine excess. These are anxieties and tremors. What is very common in patients, sometimes even if we don't see catecholamine excess symptoms, is mass effect. We talked about increasing intra-abdominal pressure, since strenuous exercise or straining or lifting can induce paroxysms. But oftentimes, patients are coming to you and complaining only about nausea and vomiting. And something as simple as constipation is a very common symptom in pheochromocytoma patients. Patients may have severe megacolons, and they may also endorse other symptoms such as hematuria. But we often see a megacolon as a finding in these patients. Beyond these 2 reasons why patients have symptoms, patients can also have non-specific symptoms. These could be blurred vision, fever, behavioral problems that can occur. Sorry. There are also other metabolic effects that can induce other symptoms. Patients, if they have MEN2 syndrome, they will have hyperparathyroidism, which is a component of the MEN2 syndrome, along with pheo, and for that reason, patients can have hypercalcemia. Some of these patients can also experience mild glucose intolerance. Patients can have lipolysis, which will reflect in terms of weight loss and ketosis. There are case reports of co-secretions of other hormones reported with pheochromocytomas and paragangliomas, but these are generally rare. What is of utmost importance here, we always talk about hypertension and we talk about paroxysms in these patients, but what often goes unnoticed is that these patient population are also prone to hypotension. And similar to paroxysmal hypertension, they also have episodic hypotension, which is seen in many patients but goes often unnoticed. And this is primarily happening because of extracellular fluid contraction, meaning the patients oftentimes are dehydrated. But it can also happen because of other reasons. Patients can have loss of postural reflexes due to ongoing catecholamine stimulation. Also, there can be an additional release of another neuropeptide, which can induce vasodilation. So we know, we talked about all these signs and symptoms, and we know none of these is very specific to the disease per se, but it's only in proportion that they occur and in combination of other symptoms or signs that we are going to consider pheochromocytoma or paraganglioma as a diagnosis when a patient actually endorses these symptoms. But you can see a lot of these symptoms are very, very common. And all of us in this room at one point or the other have experienced one of those symptoms listed here or the findings. And from a clinician's perspective or from an endocrinologist's perspective, it is important because number of these symptoms can be misleading, meaning either pheochromocytomas are delayed in terms of a diagnosis because we are looking for other conditions, and some other conditions, something as simple as hypoglycemia, hyperthyroidism, idiopathic flushing, those can be the things that can have overlapping symptoms and signs here. With that knowledge, what is of utmost importance here is that if you have a patient who has pheochromocytoma or paraganglioma, there's a key link between the clinical picture, the clinical context, as well as the biochemical finding that you have. If you have a patient who has symptoms related to pheo or paraganglioma, you will definitely find that metanephrines are going to be elevated in the blood. So that remains to be definitely in the background while evaluating a patient, and the reason for that is this is how we are going to identify our high-risk patients. We talked about paroxysms a lot, episodic spells, and palpitations, diaphoresis, headache, and pallor. All of those symptoms, those are going to be our high-risk patients who we should be screening for pheochromocytoma. But we also should be screening anybody who's had a familial syndrome that predisposes them to these tumors. Anybody with a family history of pheochromocytoma, or anybody with an incidentaloma we talked about. Anybody with hypertension and atypical diabetes mellitus with no risk factor for diabetes mellitus, and now patient has diabetes all of a sudden with hypertension coexisting. Those are going to be the adults we are going to screen for pheo and paragangliomas. Also, we talked about medications or anesthesia that can induce suppressor response and induce a paroxysms. Those are going to be our high-risk patients we should be screening for pheo. And anybody who has a onset of hypertension at a younger age, younger meaning anybody below 20 years of age, those are going to be the patients high risk for these pheos and paragangliomas. And then additional pathologies, cardiomyopathy and gastrointestinal or pulmonary tumors we talked about that come along with pheochromocytoma. Why is this important? Because all of this carries prognostic and surveillance implications in the real world. All of these tumors, as benign as they are and as apparent as they can be in their clinical symptomatology, these tumors can be easily diagnosed and properly treated. These are curable. But what happens when these tumors are undiagnosed or there is a delay in the treatment, there is a high mortality rate related to these tumors, and that is primarily related to the cardiovascular manifestations or the complications that ensue. These are arrhythmia, myocardial infarction, malignant hypertension, and stroke, some of the complications that can be fatal in these patient population. There is no satisfactory cure so far. Dr. Patsak told us about the immunotherapy approach in metastatic disease, and MBTA seems promising there. But at the end of all, from a clinician's perspective, it is very important, Dr. Patsak pointed out, where we as physicians, we need to hear from our patients and we need to learn from our patients because this is a rare tumor at the end of the day. And at the same time, there has to be this exchange of information so that we do our due diligence in terms of screening these patients. patients who are having paroxysms, resistance hypertension, or incidentalomas. We also need to know there is a key clinical link between the clinical symptoms as well as biochemical diagnosis, and Dr. Fishbane is going to teach us more about it. Majority of these tumors are benign, and there is high mortality rate when these tumors are either untreated or there's a delay in diagnosis. And I look forward to Dr. Fishbane's talk with that, and I will conclude my talk here. Thank you.